Our next session is going to be talking about biobanking, which has only arisen because of this community's effort. And to lead off that conversation, we're going to hear from Dr. Rubin.
Hi, everybody. Let me share my screen here. Okay, we should be sharing now. Yeah, I don't really have a lot to say about biobanking. I would say that, biobanking is extremely important. As you know, research is the cornerstone of what needs to be done to be able to treat this disease. And that's, I've been just unbelievably impressed with what's happened in this field over a 10-year period. I know that probably seems like a snail's pace to most of you, but to the world of science and medicine, it's actually been the progress has been really rapid. But I always think of research is medicine. You can't separate, especially when it comes to cancer. The two are so intertwined because the reality is we understand still very little about all cancers. I mean, it's only recently that we've been able to treat cancers in a rational way at all. And I've been fortunate enough to be a part of a few of these cancers, which have had alterations and things that we could understand and then start to treat them. And certainly, as you can see, there's a rational basis for how to move forward with treating EHE. So to that end, I'd like to advocate for, putting your tissue into the tumor bank. I mean, Patty can talk about it, but Patty Cogswell is running the effort for the EHE foundations, at least here in the United States. There's also biobanks over in Europe, and I believe Rubin will tell us a little bit about what's going on over there with banking. But suffice it to say that a biobank has been established now at the Cleveland Clinic. I'm not directly involved in biobanking, but I helped to broker the relationship. And we would love for patients to submit samples. And we're doing everything we can to sort of QC and validate those. Now, as you can see on our slide here, we're interested in collecting blood, ascites, tumor from at least 3 different sites if they have them, but from different sites, and then normal. And so that's a lot of work. It's a lot of coordination. Patty has really simplified the IRB process, and we are an honest broker. We're allowed to take on those tissues without getting involved in the IRB process ourselves. We can also distribute those samples to researchers in an honest broker fashion as well. I would say blood is interesting. It could be important in terms of some of the research you heard yesterday from Italy of identifying biomarkers, for instance, in serum and plasma. There also are nucleic acids in those samples that could be advantageous for some studies. Ascites, I think we're most interested in, is just a way to get more cells to grow, but also perhaps some genetic studies. And ascites, we've actually looked at a lot of ascites, and unfortunately, most of it doesn't have very many tumor cells, but we're always on the lookout for new samples. And hopefully, when we see ascites in the future, that there will be some that would have enough cancer cells to start to grow. And then, of course, tumor is the stuff that we really are interested in. And so tumor cells, could be evaluated in lots of different ways. Now, the way that we are going to process the tissue, or the blood bank, or the biobank, is the blood will be processed into plasma and PAC cells. And again, we can use the plasma for those biomarker studies and a bunch of different things. And then PAC cells are also useful for potentially immunological studies and studies revolving around what are the immune cells, because basically the PAC cells in blood are far and away just going to be immune cells. Now, in terms of prioritization of tissue, we want fresh tissue for growing tumor cells and making xenografts. And so far, we're actually just trying them at the clinic, but certainly open to Patty and your group establishing pathways where those cells can go to alternate sites for trying xenografts and cell lines. As you can see, that so far, it's cell line development, xenograft development is very difficult. We've tried a number of times, and a lot of people have, and to date, you have one human xenograft / cell line pair, and that's wonderful. That's actually wonderful progress, because when we started this, there were 0, but we need more. We're going to snap freeze tissue into aliquots. We take the tumor tissue, snap freeze it, and then that becomes something that you can distribute to researchers when they have a protocol that gets approved by the EHE Foundation. And again, Patty and your group will approve studies that are proposed and be able to send them, plasma, blood cells, tissue that's snap frozen. Now, one of the important things that we'll do, and I'm sort of volunteering my services here, is we're going to make one FFPE tissue block of each sample that is sent to us, and that is to QC it. As Christina Antoniescu just alluded to, this is not a simple diagnosis, and I know that many of you are aware that really you want experts looking at proposed EHE diagnoses. I would say we got involved with this biobank of the first 3 cases that got submitted. 2 of them were misdiagnoses. They weren't EHE. One was a classic EHE, but the other 2 were misdiagnoses, and they were understandable misdiagnoses. The classification of vascular tumors is quite difficult. So we will also do that as a QC to make sure that we're sending out EHE cases. And those are the plans so far. So happy to move to the next speaker and hear what they're going to talk about, and then we can answer questions. Thank you.
Thank you much, Dr. Rubin. Our next speaker is going to be Dr. Jones.
Hi, thank you. So again, thank you for the invitation. It's a real pleasure to talk about the UK EHE National Biobank, and got very little to add basically from Brian's presentation, just to say that I totally agree with what he said regarding research and development. So the EHE Biobank in the UK has been established. We've worked through quite a bit of bureaucracy to get it set up. And of course, the key sort of inclusion criteria for the biobank are histologically confirmed diagnosis of epithelioid hemangioendothelioma, as Brian mentioned, confirmation by an experienced sarcoma pathologist, and also included patients under the age of 16 years. And under the Ethics Committee approval, this allows prospective collection and storage of blood and tissue samples from patients newly diagnosed with epithelioid hemangioendothelioma for future research projects. And again, this slide highlights a theme throughout this meeting in terms of increased patient engagement. And of course, in the UK, the EHE Rare Cancer Charity has been instrumental in terms of raising awareness and providing financial support for research. This biobank hopefully will provide a larger group of samples, which will be valuable for future research, and as we all hope, will lead to improved patient outcomes. So in terms of the structure, this is actually within the Royal Marsden tissue bank. So samples are collected and maintained in storage by the hospital's generic tissue bank, which allows long-term storage. The biobank team has experience in sample management, and there are robust sample storage procedures at the Royal Marsden. And we do have a fairly large storage facility at the hospital. And researchers can access this biobank via evaluation by the Biobank Access Committee without the need for individual ethics submission process. So the approval process for a research project in the UK is fairly bureaucratic and to a certain extent cumbersome. And I know I've probably moaned to Brian and Hugh a fair bit about the unhelpful bureaucracy sometimes in the UK. So in terms of governance, I'm the principal investigator at the Royal Marsden. Patients are given an information sheet outlining the rationale for the for collecting tumour material and fluid, including blood. They then sign the consent form. There is a terms of reference for the biobank as well as a biobank access committee. And these tumour samples and blood samples can be accessed via the access committee, and there's a very clear policy regarding access, and we'll be updating the contact name for the biobank as Emma Perkins has subsequently moved on. So in terms of the process in the UK, patients are identified either through self-referral, through the EHE charity, or actually through our clinic list at the Royal Marsden. Patients are then provided an information sheet, given time to consider and read through the information sheet, and of course have opportunity to ask any questions regarding the process. And then we proceed to the consenting process. Internally at the Royal Marsden, this will be through a face-to-face consultation. Externally, patients can sign with the clinical team at their local hospital, and then the consent is reconfirmed over the telephone before any samples are transferred to the Royal Marsden. And consent forms can be sent to the EHE Biobank via email. And then at the final step in this process, samples are obtained, of course, internally. As I mentioned, these are collected through the biobank staff. Externally, these are collected by the local clinical team, and kits are sent out containing relevant tubes. And then the courier is organised by our staff at the Royal Marsden. So since it's been established in April of last year, again, it's been a difficult period because of COVID, but given everything, I think we've done reasonably well since that time in terms of collecting samples. One thing to note within the approval process in the UK, because we're collecting blood, that will allow us to collect ascites and pleural fluid if possible. And you can get more information from the EHE Rare Cancer Charity website, as well as the email, which is shown on this final slide for the biobank staff. So I'd like to say thank you again, and of course we'll welcome any questions at the end of the session. Thank you.
Our next presenter on this topic is Patty Cogswell.
Hi, everybody. It's nice to be here. I appreciate the time to talk with you all. I'm going to keep it really simple. I don't have any slides. My name is Patty Cogswell, as David said, and I am a consultant for the EHE Foundation and the PI of our US Biobank, and the coordinator for the process. And I'm just going to talk a little about the logistics of how this works in the US. First of all, I may have worked with some of you already, and I know Amy mentioned it in her talk earlier, that it was a really simple process, which is really what our objective is. We want it to be as simple as possible for the patients to consent and donate their tissue. So basically what I do is work through the consent process with you to answer any questions you have. And we've tried to make it really simple in that our consent is done through DocuSign. So once we've had a discussion and I've collected information, I then will send you the consent, you'll sign it, and we'll be good to go. At that point, I take over. There's really nothing else that you're required to do. And this consent can happen at any time. You don't have to be having a surgical event. At the time, you could just consent because you want to be part of the program should anything come up. And so that's basically our objective. to know there's no additional cost. I want to make sure everybody understands there's no cost to doing this, and there's no insurance related issues. There's no billing at all that happens. This is all covered through our funding at the foundation. So any tissue collected is generally tissue that's excess. So all of your care, this doesn't affect your care at all. All of your care tissues saved for diagnosis and later use at the hospital for you individually. This tissue would be tissue that's often discarded, which, obviously we've talked a lot about the need for models of the disease and to study the disease. And this is precious tissue, and our objective is to make the best use of this tissue. As Dr. Rubin talked about, and so did Dr. Jones, we were trying to make models of the disease and get the tissue into the hands of researchers. And that's one of the reasons it's really important to think about contributing to these general biobanks, because we have the ability to distribute to any researcher anywhere. And hopefully our distribution process will be a little bit easier than Dr. Jones described. I think we'll have an EHE team that will make decisions on the applicability of the research proposal from researchers, and then just get the tissue to them as quickly as possible. And then we'll also be banking for later use. And as mentioned by Dr. Rubin, we have a very large interest in ascites and pleural effusion. If you have fluid draws that are happening, we can work with you to collect that fluid and get it shipped to our biobank and get it into the hands of researchers to attempt to make models. So I think that's a really important point. In another way you can help, it doesn't have to be surgical. So basically that's all I really wanted to say. You can contact me. My contact information is on the website. Contact me with any questions at any time. And, I think that one of the focuses of this conference has really shown that patients are the central part of this. Research can't be done without tissue. You are the central mechanism for us getting this tissue. And together, I do believe we can make great strides in advancing research in this disease, finding better treatments, and hopefully a cure. I guess at that point, we'll go to the discussion, David.
Excellent. If we can invite back Dr. Rubin and Dr. Jones. And we have a couple questions that came in. One really, I think, important one here. The question is, if someone wants to donate and they're in a country where perhaps a biobank doesn't exist, can they, and how do they do that? And the specific question relates to a potential donor from the Netherlands.
So maybe I can start with that one. There probably is a process, and I'll have to look into how we do that. And maybe if I can get the contact details, I can look into the potential of working with that individual person. Be good to get Brian and Patty's input on this as well, but because I know there are issues with transferring tumor samples across the Atlantic, but good to hear what you guys have to say about that.
Yeah, Patty, I don't know if your intake process could handle folks from outside the U.S.
Our protocol doesn't allow collection from outside the U.S. I do think it would be important if we figure out where you could direct a patient that gets in contact with me. We can't do, but for example, Dr. Jones, if you could, I can send them, your contact information, and that way we don't lose samples. We've looked into collecting outside the U.S. and it's near about impossible, particularly with the EU.
Yeah, I mean, I was going to say that tissue doesn't travel international boundaries very well. Certainly we can ship everything these days and whatnot, but there's a lot of rules and regulations everywhere in the world. And it's sadly, those rules and regulations are to protect the patients, but oftentimes they just impede research. But there are things that we can't break or we get into serious trouble. Robin and I could lose our medical licenses, for instance, if we do something that's incompatible with a rule. Well, one thing we can do, so I actually know people in the Netherlands, for instance. We know the National Sarcoma Group in Leiden very well, and we could connect you with them. They have their own tumor bank. And so, things like that, I think we can do. We tend to know a lot of people. The world of sarcoma and EHE is tiny, really. We're all friends. We all know each other. And so we can help make connections potentially for folks in their countries to at least bank within your country. And then perhaps we can then set up collaborative agreements to do studies with those countries on a national. It'll be easier than a one-off basis.
I have, for other types of sarcoma, I've done something similar in the past where I've connected somebody to a team in their own country. I was going to tease everybody. Brian's so fed up of me talking about the rules and regulations that I won't get started. Otherwise, the meeting will. When Brian first met me, I had no white hair, so it's.
I spend a lot of time preparing my attempt to bail him out of jail when he gets in jail for breaking one of these rules and regulations. Don't worry, we're not going to leave you rotting in a jail cell in London, I promise.
Well, the second question that came in is very related to the answer you just gave, and it raised questions about different biobanks and what type of coordination there is out there. Specifically, it's mentioning one, I don't know that it's EHE, but a biobank at NIH, but kind of more broadly, what can you say about how different biobanks out there coordinate efforts with each other?
I will summarize in one word to say it's there's like virtually no coordination and very poor coordination, if any. It's really biobanking is one of the hardest things to pull off. I have to say, it's with all the rules and regulations, all the logistical issues. It's extremely challenging. I don't. It's they don't coordinate at all, from my experience.
So if I can comment, David, so I manage 4 other biobanks for rare cancers. And some of the things that I have been able to do is to centrally locate the tissues to your biobank specific. So for example, for the Chordoma Foundation Biobank, you can approach a hospital that has a biobank at it. And if those samples aren't being used, you can negotiate an MTA and transfer all those samples so that we get them in a central location. And that's important because researchers don't want to go to 20 different places to get 20 samples. They want to just go to one place. Now, that process can be long and tedious, but if you identify a center that's got 30, 40 samples and nobody's accessing them because it's not a public biobank, you can get them to a central location. It might take 6 months to negotiate the MTA, but at that point, then you can actually negotiate continual transfer of their samples. So there are ways to make it a more collaborative biobank for your individual cancer.
And one quick follow-on question came in and relates to the international side of this. What about Canada? Does anyone have a feel for what to do with Canadian samples?
No. I mean, there are Canadian biobanks. The sarcoma centers are in Toronto and in British Columbia. Certainly happy to connect people to the pathologists at those centers who may be managing the biobanks, but I don't have any interaction with them.
Yeah, again, I agree with Brian's comments. Transfer between countries can be really, really challenging, and a lot of work. As I mentioned, even getting the EHE Biobank established in the UK, there was a lot of bureaucracy and red tape to get everything approved.
This next question
is just within one country. So yeah.
This next question is probably best directed to Patty. if a patient wants to make a donation and they're not they're not seeing a doctor at one of the major centers where there might be a lot of information about this, is it going to be on the patient themselves to sort of initiate the process for the donation? And what are your thoughts on how a patient might need to be proactive to get a donation made?
So it's always good for the patient to talk with their physician about the desire to do this, so the physician's aware of that. But part of the collection process I do is to get all the information about the doctor's name, the hospital, the nurse contact, that kind of thing. And we certainly, for other cancers and for EHE, I've worked with people all over the country, not major medical centers, and been successfully able to collect. We ship a kit to them. We make it very, very simple. Sometimes those hospitals, it's even easier because they just do exactly what you say. They don't have a process in-house. So, like you say, put the tissue in this tube, ship it to us. You provide a return shipping label, and they're like happy to do that. Sometimes as you get bigger and busier hospitals, it's one more thing on their plate, and you have to, it's a little more negotiation than you'd expect. You'd think they'd be doing it routinely. So we can collect from any center anywhere.
Well, I would say that even major medical centers, you need to prioritize and make sure that you're advocating for your tissue to go to the right place, because one of the problems at major medical centers is they prioritize their own tissue banks. And at those institutions, there's may or may not be an EHE researcher. And so, but you as a patient have the right to direct that tissue where you want it to go. And so I would advocate for all of you anywhere, at least in the United States, that you are going to be the person who helps you and your family to get that tissue to the right place. If you leave it up to the surgeons and people that are treating you, they're super busy. This is a low thing on their priority because they're not EHE researchers, and it's very likely that your tissue won't get banked.
Yeah, I totally agree.
And we talked about in the presentations the importance of these samples that get biobanked for research. Can you give an example of the type of research that these samples are critical for? When people donate these samples, what is that enabling the research community to do that they could not do otherwise?
Well, I mean, we cloned the first WWTR1 CAMTA1 out of a patient sample, and so did Christina. Without those samples, without those fresh tumor samples, the work would have been way harder, and it would have taken a heck of a lot longer. We've now had in Italy, an example would be you've got a xenograft, a living case of EHE that's can be propagated through mice. It's been turned into a cell line. Without a tissue donation, that would not have happened. Just two examples.
Yeah, so I mean, it sounds that in terms of getting to the cure, this is speeding things up and making things possible.
Yeah, you saw there. We can test drugs now in that cell line, for instance. You can't test drugs in paraffin embedded tissue, which is what happens to your tissue. It gets fixed, it gets put into a block, the rest of it gets tossed, and it's a very limited utility. We can use that paraffin material. It's not that it's not useful, but it's limited.
This is essential, absolutely essential.
And I think one other thing to mention is, one cell line, one xenograft model is great, but it's not. We need more. We need, you can't do statistically significant research without multiple cell lines and multiple PDX models. Every patient is different. Every model is different. To come up with a combination of informations, meshing together, we need multiple models, which means we need as much tissue as possible.
Yeah, you cannot have enough models. You just can't.
Well, we're at time for this session. Thank you so much for this really important information for the community.